Good evening, everybody, and welcome to the Town Hall at ASW. I'm Mr. Zerflu, your usual partner in this extravaganza of information that we lovingly refer to as Town Hall. Glad to have you joining me tonight. I see the numbers slowly ticking up. I didn't give the 30-second countdown tonight, so I'm going to keep talking here until more of our participants are able to join us. We're available on both the Facebook and YouTube channel. The links were in both our Monday weekly message as well as e-notes tonight. And also the special update tonight had the links so that you could join us. We have quite a bit of information to trot out, but before we move on to that, I just want to offer thank you to the community. I've done it internally with my team here, echoing those thanks again for everyone's efforts during our visit of the U.S. Vice President Kamala Harris last week. We had a wonderful, unique opportunity to host the vice president, and all went wonderfully smoothly. And I want to thank all the families out there for allowing us to create that space here, to be flexible with us as we had traffic and other challenges associated with it. And hopefully it wasn't too daunting for you. But certainly we've been applauded for our willingness to host this and give the vice president the opportunity that she was looking for to meet with Ukrainian refugees in a quiet space here in this area. And a productive conversation it was that is helping to shape policy going forward. And she had some kind words for the small audience we were able to pull together. Again, encouraging all of the work that's going on that is happening behind the scenes for our Ukraine refugees, as well as the partnership that exists between the United States and Poland, of which we are all aware. So again, a thanks to all of the families out there for your support in that activity last week, and appreciation across the board. I'll talk a little bit more towards the end of tonight about ASW for Ukraine. Just a brief status. We won't have guests tonight, but I just want to give you one little anecdote and then continue our efforts. And we'll have more information about our projects and the many things that are going on at a later time. To participate tonight, you have comment streams in both the Facebook channel and the YouTube channel. If you post those comments, I'll be able to show them on the screen just like that one. And we'll be able to answer your questions. I'll also note that there was content and e-notes tonight for you to review at your leisure. And we'll discuss more how our changes are going to roll out and the additional opportunities you'll have to put feedback back to us. In addition, there was a link in e-notes tonight for a survey, particularly on some of our later stages of this rollout. And I do encourage you to fill that survey out. Also, I'll just quickly note that there was a minor glitch at the very outset of this evening of e-notes with access to one document. That's been resolved. So if you got a message that you couldn't access a document earlier, go back again. It's all fixed, and you should be able to access it without difficulty. That's, I think, the backdrop for right now. We all continue to watch and in earnest gather together as community as we face the challenges that are around us. But as a community, we're doing amazingly good work right now, both Ukraine as well as here at school, the wonderful middle school play, all of the different activities going on. It's certainly a robust and dynamic learning environment that continues on unabated despite the challenges outside our sphere of influence. So continue with that, and we'll all continue working together. I think it's time to bring Dr. O into the house. So Dr. O is joining me again tonight. Dr. O, good evening to you, sir.
Good evening. Hi. How are you?
We have lots to share tonight, but maybe before we drop into the PowerPoint, just kind of a key introductory word from you. What are kind of some of the things you're thinking about and that we should be thinking about in the horizon here?
Well, I mean, obviously, all thoughts are with our sisters and brothers in the Ukraine, and kind of everything else is second priority. And we as a company have also put out a lot of efforts and spun a lot of efforts to help the refugees both in the Ukraine and also those in Poland. As for COVID, I mean, it's it's stabilizing, and
Yeah.
obviously the numbers. That's I think I was trying to look for a good word. I think we are stabilizing. I think we are at the stage, where the Omicron variant itself, or the kind of the prevailing variant, is not as deadly as the previous ones. So we are happy with that because it mostly causes mild disease in most individuals. There is this little variant of concern, this BA2 variant or subvariant of Omicron, which may become a variant of concern, but we will see how that develops. It's less infectious but more deadly, so it's kind of mutating in a different pattern than we have seen so far. We'll see how that goes. Now, if we continue with the current wave unabated, so kind of without any influence of any variants of concern, I would say we're getting to this again stabilization phase where, barring governmental restrictions or any imposed restrictions, medically speaking, we are becoming less and less worried about kind of the acute COVID.
Right. So it's a relaxation of symptomology and particularly hospitalizations, because I think that's most telling in terms of
disease is still severe, but the flu can also be. I mean, whenever I had the flu, I was out for like 4 or 5 days, like out, dead.
Yeah.
So again, it's and that's how a lot of people feel with COVID. They're kind of out for 4 or 5 days, really, really bad. But then they're fine. Other than that, they don't require hospitalization. They don't require ventilation, mechanical ventilation, or any other even kind of more advanced medications. Now, if they do, and if they do end up in the hospital, we do have a few medications now that have been shown to work in those severe cases. So we have the simple dexamethasone, the steroid. We have the new drugs, which are becoming more and more available. So again, I think we have learned to manage the disease. So again, barring any new variants of concerns, any mutations, barring any governmental restrictions, again, I'm less and less worried about the medical consequences of COVID. Today, in the current governmental restrictions, we are worried about isolation, right? Because isolation is still there. We still have the 7-day isolation. We still need to report the cases, and we know Omicron is very infectious.
Mm-hmm.
So that's the only concern that I have, frankly speaking, is internal spread, because that would kind of take out the school, not because they're severely ill, but because the government imposes 7-day isolation on those individuals.
And that's part of the challenge that we face is kind of the inconsistent practices. And I spent some time tonight writing in e-notes about the CDC changes, which is part of what spurred our reconsideration of some of our approaches. But the CDC didn't really relax. They just changed the way that they are looking at it. And first and foremost, they're looking at it in more localized contexts.
Exactly.
So the reality is they don't look at it as a global or national decision, but they look at it as, here's your factors, kind of similar to what we're already doing. In fact, I said in the e-notes today, doesn't this look familiar? It kind of looks like what we've had.
We have been doing it for the last 2 years.
Low, medium, high profile that we established early on back in August, and how we would move between these profiles. And unfortunately, the reality of the waves that we've experienced during the first 2/3 of the year have kept us from changing those contextual levels. This will be the first time that we're ready to kind of start making some changes to those levels. We were probably going to do it back in, I think it was November, before it started ticking back up again. And we were literally on the verge of ready to relax some things. And then we had to pull back. But that's exactly what CDC changed, is they changed it to this contextual look that says you're going to move up and down this scale on the basis of your localized community numbers. And they expanded it from what we typically have looked at, which is the case counts, to include the factors you just mentioned: hospitalizations, actual seriousness of consequences, per 100,000 kinds of numbers, trend lines, and said, okay, CDC says now you're going to be in a low, medium, or high, and here's what you do in each of those categories. Again, very similar to what we've already laid out. It's just, it's interesting to me that it's hard now to really characterize waves anymore, that it's going to be much more localized in terms of looking at what your current circumstances are. And so being able to say Europe or Poland or North America is going to be hard to say that there's any one particular number that describes that whole entity.
Which is exactly where, the endemicity comes into play, because it's less of a pandemic, it's now an endemic disease.
Which is what we've been predicting for
localized, which is what we were predicting, which is localized. And as you say, John, we may be seeing these, macro waves like we see with seasonal flu, for example. But we will be seeing a lot of these micro waves, micro outbreaks, even at the community level, like ASW will be kind of a micro community, not necessarily even Warsaw or Constantine. And that's where decisions will be made, even again by localized organizations, whether it's a company, a production facility, or a school, or a city, depending on many factors, and obviously one of those important factors will be the level of vulnerability of the given population vis-a-vis the availability of beds in hospitals in a given micro population. Because if you have a very vulnerable population and you have few beds, obviously you need to protect that community. If you have a low vulnerability population and you have few beds, you don't really care. If you have low vulnerability, a lot of beds, also you don't care. So that's where I think this kind of simple 2x2 will come into effect, where on the one hand you will have kind of the availability of healthcare resources, on the other hand the vulnerability of the population, and then you will make decisions based on the dynamic on these two axes.
But the underlying principle, just to put a fine point on this, is that the shift from pandemic to endemic is, in a pandemic, we're wanting to avoid illness and not let it happen to us. And we know that a percentage isn't going to be able to be protected, but we try to protect everyone. Endemic, isn't there just an underlying expectation that a certain percentage of the population will get sick? And maybe on a regular basis, if we're looking at a flu-like endemic, where you're going to be vaccinated, it's not going to be serious consequences, but every year you're going to have these symptoms and they're going to go through a week of this.
Absolutely. This will be just another upper respiratory tract infection. Again, we have to be vigilant, obviously, and in the last couple of years, we have done so much in the ASW community that, I believe we are very well prepared for a potential variant of concern.
Right.
And we have to be vigilant because, again, we have seen this virus mutate either way. And, today it's Omicron, tomorrow it may be BA2, and it will be a different story. But again, we know how to monitor the situation. We know what to monitor. We have the tools to manage the situation in a dynamically changing environment, and to make sure that, again, depending on the situation, we kind of push the various buttons and we implement the various layers of the Swiss cheese to ensure the safety of the population. Today, we can kind of say, okay, maybe we can start removing or kind of thinning down these various layers of the Swiss cheese.
And speaking of that, here's our Swiss cheese layers that we've had in place, including our enhancements. All that black text up there is the things that we added into the original model that we've implemented over time. So, just as a reminder that this Swiss cheese model is about understanding that each layer of the Swiss cheese is not 100% guarantee. It may be varying levels of percentage of protection, but taken together, these all work hand in hand. What we're going to be suggesting tonight is that we can relax on some of these layers because some of the other layers may be sufficient in this current level of spread to protect us enough that we don't need the additional layers that get us that extra 5 or 2 or 1% of protection because they're sandwiched together. So just to make sure everybody understands, this is where we were and this is where we started and where we've been until today. And what we're going to propose tonight is an incremental approach that suggests we can start relaxing this while, as I think you're saying, we remain vigilant of the potential we may have to pull back to these layers again in order to protect the population if we have a variant that is more serious or has a higher frequency rate of more serious consequences, which I think is the greatest concern relative to risk. So let's talk about our summary. I mean, we always start with this and understanding about where we're at. We're not exactly in all these categories yet, but we're pretty close, particularly if we're looking at 7 and 14-day averages as opposed to any single day. The numbers do go up and down a little bit more. They gyrate based on weekends. They're low, and then midweek, they're back up again. But the general trend line has been positive, particularly in that first row in the 7 and 14-day average daily case counts. I think we saw 5,000 on Monday, and we saw another 12 or 14K today. Last week was, I think, better with it hovering more around 10K or just under it. So again, monitoring, vigilant. As people relax, the numbers go up. So we expect they might go up a little bit more before they come back down again. We are seeing a positivity rate that's stabilizing at the bottom end of that 10 to 30 range. I think, Dr. O, you quoted 15 or 12 or something like that.
That's kind of where we are, I think, seeing right now, kind of in the low teens.
Yep. Our weekly case count is still up and down a bit too. We had some good days last week where we had 0, and we actually canceled our meeting for the first time in a while. But then we ticked back up again, and it's predominantly, we believe, Omicron, because it seems to be easily spread outside, and particularly in families. The cross infection in families has been particularly pertinent to our caseloads. So we're still on that edge between 5 and 20 on a given week. The internal spread still seems to be fairly low. In fact, I'm not sure we're in that 5 to 10 range. We may be really borderlining on the 1 to 5. These are only possible internal spread. Probable is the word we use here, so it's kind of a subjective call. But the vast majority of the cases we've identified as predominantly outside sources.
Yeah, it's actually, I was reflecting on this because we kind of said that our protocols should reduce the probability of internal spread by about 90+%, 95+% even. And I think we are probably at that level, around kind of 5% of our cases were probably somehow internally spread, versus 95% of the cases, and that's a lot. We've had quite a few cases this school year, were outside imports, let's say, or outside contracted cases.
And that's the piece, right? As we're continuing to reflect and review on that, and it does seem to bear out that the protocols that we're using in school are reducing the spread here. But outside of school, in settings where masks aren't worn, where there's exposure to crowds, those kinds of things, and particularly in families and in households where there's a high degree of close contact, that's where the spread is taking place. That's not to say we're without internal spread, because we do have cases where evidence would suggest there is a real potential that was an internal spread. The vaccination penetration we're doing quite well on. I think might not be totally above 70, but it's in that neighborhood. I would say 63 to 70 is probably where we're sitting, and that's including staff in with students. The elementary vaccination has gone well, both our events as well as parents getting vaccination for their kids on their own. It's disappointing to see that our 3 to 5 year or 5 and under vaccine was not going to make it to the table. That's not under our control, but the approvals for the under 5 have been pushed back a bit, and we're waiting to hear what's going to happen there. But we're definitely, with all in, we're definitely looking at that, like 65, 70% range in our vaccination, which is different for our micro community than the general population, as we all know. That's one of our challenges, is that the actual uptake of broader vaccination is probably still in that upper 50 percentile range. But for our community, we're at a very good place and a very good number. On the basis of all of that, and while it may seem a bit premature, we feel comfortable suggesting that we're now ready to be at this risk level 2. And that's a move down. We were kind of hovering in between 2 and 3, maybe a little bit more in 3 for an extended period of time through these waves. But we see enough indication of trend line on the data above that we're comfortable saying that we're solidly in level 2. And remember, level 1 is really no risk. And so we're on the right path, and that's our belief.
And again, if we were, still in the Delta wave, I would feel much more strongly around the 3 number. But now that it's Omicron, I think the 2 is fully justified, even with these numbers kind of hovering between the low and medium.
Right? Yeah, exactly. So our items of announcement tonight is that we're going to be moving somewhat generally from medium to high. As we've said before, we don't do all of these movements in mass. We look at each category of mitigation and determine for each category, based on the evidence and other points of consideration, whether we're ready to move from medium high to medium low, or whether we feel it's important to hold on that criteria for a period of time. The other thing we're going to share with you tonight is that we've spread these out over about a 3 to 4 week period so that we can monitor each change and determine what the impact of that change is to our statistics. And that's something that we can do as a micro community that's harder to do in general population. There's a lot of conjecture out there about, countries and areas that are relaxing their stipulations and whether or not it's too early or not. And it's hard for them to determine until it's too late because they're not really tracking data while they're making those changes. So we have the unique opportunity to be able to track our change and monitor our progress along the way. So this is where we're going. Leah, I just had a question here. Leah said, where does the 95% statistic come from? And I apologize, I didn't catch that comment early enough, Leah, to know what that was related to. Dr. O, do you think?
Oh, I was stipulating that around 95% or so, 90+% of our cases were externally contracted.
I get it.
And
this predominance of the data.
Yeah, this statistic comes from our daily crisis team analysis of all the cases, where one of the items that we analyze for each case, as you may know, is the potential source. Because we want to determine and make sure that, again, the source, where if the source is internal, then we implement other measures than if the source is external, because then we look much more closely. So that's where this statistic comes from.
So thanks, Leah, for the clarification there. Yeah, the mitigation strategies. And that's, again, and there you go. Thank you from Leah. See how the comments work, everybody? Just throw your comments up there. And now I'm watching, so I'm going to make sure I stay on track here.
Yeah, I see them too, so I will also be reacting.
So again, what we're going to do is for these areas, because these are our areas that we've chosen to focus on as we look at the next 3 to 4 weeks of where we want to make changes and how we're going to incrementally roll them out. And doing this on essentially a Monday implementation over the next 3 to 4 weeks for each of these categories. And what we want to do is take you through each one of these categories and explain it to you and make the link back to the longer document. Now, both the link to these slides and the document were in eNotes tonight, so you can go read in more depth the document. I apologize if there's still a little grammatical problems in there. We did as much editing as we could. There's probably still some errors. And again, we're trying to clarify and make sure it's absolutely clear for everyone from the document we've been working from this year. But let's start with events. This is kind of a low risk area because we've already been dabbling in this area, and that's using testing for admittance to events. What we would do is move to the low profile. We've been at medium, and say that we can return to less restrictive seating plans and cohort mixing for events. So that means primarily at upper school, we feel like we can mix a little bit more. And then tested audiences. This is primarily for parents, for more events as possible. And this is just about time and resources more than anything else. But open it up. We had been restricting it or limiting it to just parents of the performers. For selected events, we want to open this up a bit more broadly and see if we can do more of this, which I think opens the door to more and more of our activities, including a broader parent audience. And again, this is kind of a low risk one. We haven't seen huge issues with these types of events, and we've already been dabbling in this at the medium level. So this is a pretty easy one for us to move into the low territory.
The testing for admittance has worked quite well, and I think that's important that we kind of do the test, and to stress that the test has to be done kind of rather immediately or kind of on the
right
day.
Before. Yeah, and we've meandered that. We actually have trialed having it be a bit earlier in the day. I think we've got a 6-hour time frame that we use as our benchmark right now. But that it's a good point that that's what we're looking at as a way of. And by the way, I think that matches some of the government standards as well for this test to stay or test to continue working kind of strategy. That 6-hour framework. At the parent level, we're going to remain at medium until the family infection rate drops. I think we mentioned earlier that a large number of our cases, I can't specify a percentage, but it's definitely high frequency, have been result of internal family spread in households. This has included in many cases parents who have turned positive through workplace identification, and then ultimately the kids are testing positive as well shortly thereafter. I remember, Dr. O, in the early days under Delta, it seemed like we were having family spread only about maybe 20 or 30% of the time, and that we would typically have most family members be able to avoid, if they were doing general isolation, spreading it to each other. And now it seems like because of the increased virulence of Omicron, not virulence as the word I'm looking for, but increased spread, infectiousness, that we are seeing families take the brunt of this.
Yeah. It's unfortunately, without the kind of the basic even protection like masking, testing, etc., it's very difficult to keep Omicron abreast. So as much as even with Delta, kind of the normal isolation within a house worked. Here, even isolation within a house where you kind of mix for a few minutes in the kitchen does not work anymore.
Yeah. And of course, we don't track necessarily all parent infections, so it's hard for us to keep a close watch on this other than through the cases that are ultimately reported to us via students. Yes. But we think as a team, it's prudent for us to maintain our current program at the medium level until we have a better indication that we have that spread and that community incident rate under control. The low level, just to look ahead for the future, would have us opening more areas to parents within the context of the school, with possible stipulations or limitations yet to be discussed, but those are for the future. Leia's asking again, do you know the positivity rate amongst the ASW community as a whole? Dr. O, you'd have to help me with the math on that and whether that's something we have or could calculate. But I think we suggested the positivity rate was, in a general sense, below the external positivity rate in terms of the positive number against those being tested.
Yeah. No, in general, I mean, so we are testing. We're doing about 2,000 plus tests per week, and we have about 15, 20 cases per week, let's say, plus minus. So that's a 1% positivity rate.
Yeah.
Okay. So versus kind of 15% for the country. So we're 15 times lower positivity rate in the school than in the country in general. Remember that we are also, it's a completely different methodology, because for the country, you don't test the same person twice a week. It's kind of, a person tests when they're sick, because normally you don't test people who are healthy. So it's a completely different also population, because it's already positively selected for disease in a way. Because the people who come for testing, they usually have some symptoms, or they have somebody who has symptoms, or it's, again, there is some selection. We are kind of screening, so it's also a different methodology, which is also why, in a cumulative way, we have a higher positivity rate than the country, because we're testing everybody regularly.
Right.
But again, when you look at the number of cases which were probably contracted inside the school, it's about 5%. So when you factor that in, we actually have way, way, way lower positivity rate than the country. If you count the internally contracted cases, because the rest is kind of the community spread. Okay, so that's that there we don't have much, and that should be in line with the general population. Except again, the general population is not tested twice per week.
Right. So their actual testing count is lower than it should be if it were more broadly done. So you're right in that it's hard to compare those, because it's really comparing apples and oranges.
Exactly. Because if we were to compare, we would have to see kind of about 30 million tests done a week in Poland, to kind of count the mobile population.
So the question here is about expansion of event attendance. That's because the event attendants would still be parents, but it is a controlled environment. So it's excluded from what we're talking about in the parent axis. The parent axis is normal school day, uncontrolled or moderately controlled access to areas in the building that we currently restrict only to the pre-approved parent volunteers right now, or those that could potentially opt into a testing program. So this would be test to attend is separate from that. This is generalized parent access, which is why it's different, why it's not the same as the two categories. I hope that helps understand, but that's the differentiation between the two. The test to attend program is a much more controlled environment, and the expansion of that is we would just allow for more testing at more events so that we could have more people involved. And we would expand the audience so that there are other parents who want to see events who don't necessarily just have kids in those events could also attend. This opens up to other family members, friends, those kinds of things that used to come to events. It would just be under that testing before entering protocol. Let's see, got a few more questions up here. In today's update, it was mentioned that the symptoms are very much the same now. Could you share what is the symptoms picture we see now? I don't know if I said it was the same now. I think I said it was less, but Dr. O, symptomology. We were talking about that earlier, but.
Yeah, again, in general, it's an upper respiratory tract infection. So you kind of have the typical symptoms of an upper respiratory tract infection, which is, nasal congestion, which is runny nose, which is cough, which is itchy throat. It's very typical. And what we are not observing that much is this extreme triggering of the immune system, which resulted in this extreme mucus in the bronchi and in the lungs, which led to those dyspnea, apnea, hospitalizations, ventilation, etc. So we are not seeing that. So we are seeing kind of the more typical, again, upper respiratory tract infection syndromes, versus in the Delta and the Wuhan variant, the Beta variant, the Alpha variant, we have been seeing much more of the lower respiratory tract
Mhm.
type symptomology, which again resulted in much more severe disease. We're also seeing obviously other symptoms, but again, I'm talking about the typical symptomology, but we're seeing more of the kind of even gastrointestinal symptoms a little
But
bit.
but one thing we've definitely seen under Omicron is, and I think this was what I was trying to say, is symptoms emerging before infectiousness.
Sometimes, yeah, sometimes. So
So that's been frequent for us within the last 3,
it has
4.
been frequent, which again is uh, because it's a bit of a different virus. Again, this virus has like 50 plus mutations versus the Delta. So whereas the symptoms before, they were caused rather by the extreme immune system reaction to the viral infection. Here, the symptoms are much more localized to the kind of mucosa of the upper respiratory tract, so are a direct result of the viral infection.
Mhm.
So you need much less of the virus. That's the kind of what I'm trying to say. You need much less of the virus to cause symptoms. Before, you actually had to have a lot of virus to have this extreme reaction of the immune system. Now
Right,
you have a
which
little
is
bit of
that's the sore throat and the runny nose and
exactly. That's
early
a little bit
symptoms.
of the virus, which sometimes is not detectable by the antigen test, which means you're actually not even infectious when you
Mhm.
have symptoms. That's the kind of a bit of a paradox, because before we were seeing that people who were tested positive, they usually develop symptoms a day or 2 days later.
Right, which goes back to the other thing I was gonna say is in Delta waves and in the previous waves, we were predominantly identifying cases asymptomatically.
Yes.
And now
Very
we're
little
seeing
of that
far
was
more symptomatic cases that were symptomatic a day before, or even in some cases a few hours before a
yes.
positive test. So that's the what I was trying to refer to
Yeah.
in the symptoms is the changes that we're seeing symptoms earlier. Now, that's potentially a good thing because what that has also spurred, at least in our community, and we're going to talk about this, I think, in the next slide, is the symptoms are causing people to do home tests earlier
Yeah.
and therefore catch infections before they ever show up at school. So we're getting far more home testing that's informing us of a case and reducing our need to do contact tracing and potential exposure tracing
Absolutely.
because we're catching it before it becomes an issue for us here at school.
Which I think is exactly where we have always kind of stipulated from the beginning that this should be the standard, that we kind of all have home tests at home, and then if something we feel is wrong, then we do a home test and then we isolate ourselves. We don't report anything, but we kind of isolate ourselves, and that essentially would kind of eliminate the disease. We had to implement a different program, obviously, but once we go into the stabilization phase, maybe this will be the approach.
Mhm.
We will see.
Parents asking about the volunteer program. It's a program that's been in place with PTO to kind of validate a set of volunteers. We had limited numbers because of it's the school that's actually doing the expenditure for that. We could begin to expand that program even under the medium protocol. We did try to launch a parent subscription program to testing back in the early days. There wasn't much uptake in it. But ultimately, it's still about, at the medium level, a testing program that gives a person access to the building. At the low level, we may or may not have testing as a component of that. And that's why we're not ready to move to the low level yet. And that would open up the expanded access for parents. So I hope that helps to explain it. I know that feels kind of disconnected, and we should probably talk about that further. We do want and appreciate volunteers, and that number that we establish is just pre-existing. We could examine that number and see about how to expand it, but it does mean essentially that the parents that we're allowing to interact in the facility are only tested parents that are doing the testing regime at whatever level we're currently asking the testing to be done. Dr. Leah has one more. What's the percentage of hospitalization after infection? Does that affect our decision making? Well, I think it does. I think that was what we started with, is that there is a reduced hospitalization. That's part of why we're incrementally rolling out some changes tonight. But there still is that possibility of hospitalization and the possibility of more serious consequences that's hard to predict.
Correct. I mean, it's again, as I said, it's still a serious disease. It's not, it's not just a runny nose. It can become a serious disease, especially for those vulnerable. We actually don't understand, still who is vulnerable. To be honest,
That's the other piece, the mechanism of identifying. Originally, it was the vulnerable populations, immunocompromised, but it's really not, because amongst the general population, there still is a percentage that
we don't know.
We're seeing it now. It's the people who are getting it for the third time or the fourth time, right? Because they're getting reinfected.
And we will probably understand at some stage, a few years down the road, when we kind of understand this whole proteomics, genomics, metabolomics of the whole viral infection, and how people with certain genomic profile, proteomic profile, may become more susceptible to specific diseases like SARS-CoV-2 or others. But today we're kind of still in the clouds, with this one, and we're kind of say, oh yeah, the hypertensive and diabetic and obese and elderly. Okay, but that's kind of you could say that for any other disease probably and still be right. So that is it's still correct, obviously, but again, it's not rocket science to identify those populations. I think the rocket science will be to say, of those healthy ones, which are the ones who are most likely to end up in hospital with SARS-CoV-2.
Right. And then you can do some mitigations specifically.
And then you get a mitigation. If you know you have to, then you can say, okay, so I'm stuck with the mask for another few years, probably.
There you go. All right, that brings us to testing. So this is probably the bigger one, and we're not starting this until March 21. Is that this coming Monday? I guess it is Monday. So we decided this is the one we're going to start off next week. Along with the two we've just talked about. And we are ready to move back to weekly testing. So Dr. O, why don't you talk about that?
Well, we have kind of always stipulated that when we go to this medium level, this would be the recommended testing frequency. And as you remember, we had this, I think we call it weekly plus approach, which has been in many studies shown to be, with this kind of level of community spread, the kind of optimum approach, which is we do everybody weekly. And then whenever we identify a case, then we do the off-cycle test for the cohort, and the cohort can be either close contacts, or it can be a grade level, or it can be just one single grade, or the bus. And we have done this, we have used this approach in the past. So that was our kind of typical approach, with the kind of low to medium level of community spread. With the high, we moved to twice weekly because that was the better approach. Here we feel that with this community spread, and again, we will be observing, obviously, and we can always increase the frequency of testing. But I think at this stage, we feel comfortable and confident that the weekly testing, especially again with this prevailing symptomology that we see, so the symptoms usually precede the test, that weekly testing with off-cycle testing and rigorous exclusion of symptomatic individuals and home testing of those would give us the same level of protection as twice-a-week testing.
So that's important to emphasize. And let me first start by saying that our strategy when going to once a week is we're going to spread our cohorts across the week. So right now we're doing essentially a 2-day cycle, 50% per day, twice a week. Monday, Tuesday, Thursday, Friday. Now we would go to Monday, Tuesday, Thursday, Friday. We'd be 25% of our population each of those 4 days. And so that's what we'd be starting next week. And we're already developing our schedules to implement that starting on Monday. But as you just pointed out, our recommendation is home testing, particularly in the face of symptoms. I think I've heard multiple jingles in the United States where testing has become more fully available. If you got symptoms, that's when you use a test, or if you're going to an event, and you want to know that you're safe for that event, that's a use of home testing. But it's not a test to be used when you think you've been exposed to COVID, because for that you want to wait 3 days. Exactly. And you want to wait before using that home test. But there's methodologies, all that stuff's out there online. People can look it up as well. We also want to reinforce daily attestation. It is working for us. We want to keep people focused on that. We may update some of the language on OK for School and update it a bit to continue to focus on really thinking through symptoms and making sure that we're staying out of school and until we're tested either home or at school to assure that symptoms are not related to COVID. And we do know that kids get sick for other reasons, but you understand that. You've all been doing brilliantly at this, keeping kids out when there's any level of concern until a test is done. Many of those tests end up turning up a positive case. Others do not, but it's a great way of making sure we stay safe here at school. And then we threw one other in there that I just want to explain, and that's this grace period for recovered. Because of the family spread, we were taking even recovered individuals and moving them to test to stay if another family member became sick right after their recovery. We're not going to do that anymore. And this is based on a lot of conversation and review of the literature. But the recovered really does have a 2 to 3 week grace period after recovery when we don't need to apply any additional testing regime if another family member in the household becomes sick. So just know that we've implemented that as of this morning, and that'll continue into next week.
Yeah, so that's important to specify that this is for the kind of household transmission, where, again, the likelihood that it's the same variant is very, very high, and the likelihood of reinfection of the same person within this time frame is very low. And within the 2 weeks, probably the domino will end.
Yep. And this was, again, initially based on the fact that we were seeing more reinfections, not a lot, but there's this small percentage of reinfections within the first 3 to 5 weeks after recovery.
Yeah.
So and that was part of what we were initially concerned about, but it is a very low percentage. So we don't think there's additional risk by relaxing this, at least for the 2 to 3 weeks after recovery that we've specified. But there is, I just want to reinforce, there is a danger of reinfection in the 4 to 6 week range. Yeah. And Dr. O, you can confirm this, where there is kind of this flattening out of antibodies, right? And there's this risk.
Yeah, there is. It's this. When you're ill, you have these acute phase antibodies, these IgM antibodies, which are spiking, and they kind of are spiking a few days after infection, and then they last for about 2 to 3 weeks. Okay. Then you have the memory antibodies, which develop as a result, but they develop 4 to 6 weeks later. So you have this window, kind of between 3 to 4 weeks, 4 to 5 weeks or so, where you have already declining IgM antibodies and not yet developing IgG antibodies. Okay, so not yet the memory antibodies. And that's where, at least theoretically, from a kind of immune system perspective, you have the lower, or you have a trough in your protection, at least from the antibody, from the B cell immunity, so kind of the antibody immunity. You will still probably have the T cell immunity, obviously, but again, from the perspective of the comprehensiveness of the immune system, you are in the trough of one of those arms of the immune system.
And this was, I remember when we were going through Delta, that the blood antibody tests, we were recommending people to wait 4 to 6 weeks before doing that after infection to check their antibody levels, because it would be low after infection and wouldn't necessarily show the developing immunity. Same for vaccinations. Your true full immunity is 3 to 5 weeks after that second dose. And so this is just a cautionary statement, because I think the gut reaction of somebody recovering is, okay, I've recovered, so now I can go out and do whatever I want to. And the reality is you probably should be cautious for that 4 to 6 weeks until your immunities have built up. And again, you should talk to your doctors about this, of course, at
Yeah,
all times.
and
But
obviously, any infection weakens you in
mhm,
general. So you have this, general weakening because the immune system is in overdrive for a few days, and then obviously it's kind of exploited, over these few days. So it needs a rest, and while it rests, obviously, while you're thinking, oh, now I can play and party, then which is when you get into trouble. Not necessarily even from COVID, but from other things as well.
could be other diseases as well, because that's when you're down at your low level. All right, well, let's talk about cafeteria. We think that there's room here starting on Monday to move to some broader services in the cafeteria. They won't all be implemented at once, but we've given them word to refresh some of their prior programs. Some of our fresh items, like our salad bar, can begin to come back. Again, a lot of the research and data suggests that those areas were not areas of distinct spread. And certainly the research is proving that out. And maybe some relaxation of cohort mixing in the cafeteria and some of our distancing. We have not pinned much of our spread over the last 2 years to cafeteria, despite what people think about, the relaxed mask wearing in there in order to be able to consume food. We actually haven't seen spread associated with lunch or cafeteria in our data now going back 2 years. So we feel very comfortable moving to low in the cafeteria setting. Cohort isolation, moving from medium to low on the 28th. So we're going to wait a week on this, but this would allow us to begin mixed use of cohort areas that we had highly restricted. That means in the library, potentially taking down the barrier between middle and high. Looking at some open time access before and after school, potentially. Some general mixing in areas that we consider common areas, cafeteria, gyms, and sports facilities, but still under a slight amount of control, but generally relaxing some of those boundaries and some of those barriers that we established early on. And that might be incremental again in nature, starting on the 28th. It might be some things early on and other things later. And I'll try to give more detail on this, as I will each week in the weekly bulletin on Monday, to tell you what kinds of things we're implementing that week in order to give you a heads up. Let's see. Does relaxing cafeteria price mean my middle schooler can have access to drinks, since we have only been here during COVID? I'm not sure what normal. I'd like my student to be able to buy from those cafeterias with his lunch money. I mean, yes, there is a possibility. There is definitely a possibility we'll be able to access that. I think we have a lot of that access now, but it will expand. The other thing, by the way, that I include in here is we're ready to bring microwaves back for kids to heat up meals that they bring from home. I know that has been one that's been gone for a while, but I think we're ready to redeploy that. Again, details of this I'll try to flesh out in a weekly to try to answer some of these questions. But the answer to this question, at least initially, is yes, that will begin to expand in terms of options and things that are available. Okay. All right. That brings us to mask wearing. Dr. O and I are still mulling this one. So this is why this one is labeled as tentative. We know that this is a hot topic amongst our community on both sides. We want to continue to study this. We wanted to set a date for projecting this as something that we feel, if these protocols that we're changing over the next 2 weeks follow the course we hope for and the numbers remain in the target range, that by April, sometime in April, we'll be able to relax mask wearing to some degree. The details would come. Again, a lot of this is related to the CDC criteria that was established that started to relax masks based on the additional criteria for managing that. It would be a program where, while we would relax, we would also support any individual who wanted to continue wearing masks. It's not that we would be saying no masks. We would just be saying those who feel comfortable with the risk related to this would be allowed, potentially in indoor spaces. We would continue mask wearing on confined spaces like buses and other forms of enclosed transportation. Again, this is projected, and it might reduce our contact tracing. We might monitor differently, and might not be reporting significantly close contacts or requirements for additional testing. Again, moving in a way towards this endemic phase. But this is under advisement, and we're watching carefully to determine whether we can implement this last phase. And a survey is out with e-notes tonight. And we're very interested in your opinion. I know in the early results, it was generally showing a little bit of a split. And it's not the only thing that we'll be looking at. We are looking at the actual results of our changes, not relying entirely on the survey, but we want to be informed with a survey to help make sure we're heading in the right direction. So please do the survey. It does require you to have your MyASW key, so you're going to have to go out and get that login sorted and make sure you can get to that. But this is what we've got on the horizon in a much more real sense than we've ever been talking about it before. Dr. O, your thoughts on this? This is, I know, our challenging one.
It's a challenging one. And, obviously we still have the mask kind of mandate in Poland in public spaces.
That's part of the issue here.
It's part of the issue also. Yeah, we will be monitoring. I mean, masks have been quite effective, obviously, in reducing transmission, and we see it, and it has been documented elsewhere. I think the CDC approach is practical, so let's see. I think we can certainly consider this approach once we kind of again see that the other stipulations which we have introduced, the other relaxations, actually, again, as you said, are putting us still at an acceptable level of transmission.
Yep. And I know that it's somewhat intentional to save this to the end to see how the other factors impact us, because we know this one will be more significant. And again, it could be a situation where we try this and find out that it increases the caseloads, increases the transmission, or forces us to take larger groups into time out of school when a case emerges, because we won't be able to easily identify close contacts or differentiate them when we're in a maskless environment. And so it might spur us to go back the other direction and bring masks back if we see that it has that kind of negative impact. So monitoring going in, monitoring while we're doing it, and maintaining the potential that we might have to back up a step because we went maybe a bit too early before we were ready. And that's our mantra for right now. Again, fill out the survey, give us your feedback. We are open, and all of those who have written to me previously about this, all of your messages have been read, digested. Dr. O's seen all of them as well as I have, and the survey results as well. And we do take all that into consideration. That's why we know that this is a highly debatable one, and one that will inspire a lot of beliefs one way or the other. We're trying to make as prudent a decision as possible in the time between now and April to make the right decision. Okay. That brings us to the summary. So just to summarize, and this was in the e-notes tonight in this form, March 21st, expanded event access, tests to come in, relaxed cafeteria practices, and we moved testing to once per week. We watch how that goes for a week, and then on the 28th, we add additional relaxation to cohort isolation in various facilities and pathways. By the way, that also means we try to kick off more access to swimming, get the pool back in gear, and get some of our grade levels back in for the time that they've missed. There's already a plan in place for that. And then April 4th or thereafter, sometime in April, I don't want to be specific about the 4th, we relax the indoor mask mandate. And this is, again, conditional on case management, home testing, attestation, survey results, all the things that we're doing from now until April that'll give us a sense that we're on the right path. Here we go. Other questions out there, please shoot them at us. You've done a good job giving us questions for us to mull tonight. Are there any others out there that we can answer before we bring tonight to a close? I'm not seeing any. So, Dr. O, as always,
Thank you.
thank you. The partnership continues, and again, we appreciate all of your efforts in conjunction with ASW and making this all work.
A pleasure and an honor. Thank you very much, and have a good evening.
All right, bye-bye now. So, saying goodbye to Dr. O, I just wanted to spend a couple minutes on Ukraine. I'm going to go back to my banner and remind you of our ticker. We have ASW for Ukraine as our hashtag, and there's a lot going on. Our webpage is up and it's being updated regularly. Our donations are coming in and now being deployed to activities that are in support of our refugees. But I want to share one little anecdote with you tonight, and I'm really excited about this one because we've just today worked towards scheduling a time with her. But I want to introduce you to Eloise. There is Eloise, and we became aware this morning that Eloise is in New Jersey, and she's making buttons for Ukrainian refugees. And here's the interesting part. Unbeknownst to us until this morning, all of her proceeds are coming to our fundraising campaign on Rally Up for our Ukrainian refugees. So Eloise is very excited about this. She's also partnered with a restaurant in New Jersey called Basilico. And these are her Love for Ukraine buttons that she's making and selling in order to send the proceeds to our ASW for Ukraine fund. So I just wanted to share that one with you. There's lots of goodwill. People are sharing with family members all over the world. And we're seeing that come in the way of love and donations. We're getting calls to help refugees on a variety of fronts from around the world as well. We're thinking about sustainability and onward for our refugees. And I just can't say enough about Ligita's Mili and the team, Maria, all of the folks at PTO, all the parents that are chipping in. I can't even begin to list all the names here, but I know I wake up every morning to WhatsApp chat that's saying, here's our mission today, and here's where we're going to be, and what time, and moving things. We are processing a significant amount of donations, actual goods that are being sorted, packaged, boxed, and sent on to refugee centers hither and yon. So we are making a huge contribution to this refugee support. And I just had to share Eloise's story as a small drop in the bucket. And I think we feel at times like we're just a small drop in a bucket, but actually we're a pretty significant drop. And we're making tremendous headway in serving this population that's been disenfranchised from their country. And I know we all feel for that and understand that. And we also are in it for the long haul. We know that we've got to continue to build towards sustainable practice and taking this forward because it is going to be an extended period of time. I also want to add a note and a thanks to teachers and staff and the admissions department for processing our dislocated families out of CISA schools from these affected areas. They are starting to join our classrooms, and it's just been a joy to be able to serve those individuals in a positive way and give them continuity after they've been ripped from their homes. And it's wonderful to have them in their midst, and I do welcome them. I've met many or had meetings with them, and they're so thankful for this opportunity for their children who had nothing left after they were forced to move. So again, welcome to our community, and I hope that you find an opportunity to meet some of them and wish them well as they're trying to make plans for their family for next year, given what they've now faced and searching for options. So just another piece of this puzzle, but certainly another area where we're serving the greater good. That's ASW, changing the world for the better through all of these activities. Thank you, one and all. And to all the students who are actively involved every day in all these projects, thank you. You are doing wonderfully good work. That's it for me this evening. I hope you have a wonderful remainder of your evening. If you have any questions, please feel free to reach out, fill out your survey. Go check out on the e-notes tonight the listing of new staff. I posted that tonight, so you're able to, if you got your MySW key up and running, you're able to log in and take a look at our new staff bio pages, initial introductions. We met with them today. They're very excited about coming. They're getting their things together, starting to consider what's going to be packed, and we'll be seeing them in August. Okay. That's it for me. Have a wonderful evening. Off for now.